Welcome to SLP Nerdcast. I'm Kate.
And I'm Amy, and we appreciate you tuning in. In our podcast, we will review and provide commentary on resources, literature, and discussed issues related to the field of speech-language pathology.
You can use this podcast for ASHA professional development. For more information about us and certification maintenance hours, go to our website, www.slpnerdcast.com. SLP Nerdcast is brought to you in part by listeners like you. You can support our work by going to our website or social media pages and contributing. You can also find permanent products, notes, and other handouts, including a handout for this episode. Some items are free, others are not, but everything is always affordable. Visit our website, www.slpnerdcast.com, to submit a call for papers to come on the show and present with us. Contact us anytime on Facebook, Instagram, or at info@slpnerdcast.com. We love hearing from our listeners, and we can't wait to learn what you have to teach us.
Just a quick disclaimer, the contents of this episode are not meant to replace clinical advice. SLP Nerdcast, its hosts, and its guests do not represent or endorse specific products or procedures mentioned during our episodes unless otherwise stated. We are not PhDs, but we do research our material. We do our best to provide a thorough review and fair representation of each topic that we tackle. That being said, it is always likely that there is an article we've missed or another perspective that isn't shared. If you have something to add to the conversation, please email us. We would love to hear from you.
Before we get started in today's episodes, financial and non-financial disclosures, I am the owner and founder of Grand Bois Therapy and Consulting, LLC, and co-founder of SLP Nerdcast. Amy Wonka is an employee of a public school system and co-founder of SLP Nerdcast. We're both members of ASHA SIG 12 and both serve on the AAC advisory group for Massachusetts Advocates for Children. I am a member of the Berkshire Association for Behavior Analysis and Therapy, Mass ABA, the Association for Behavior Analysis International, and the corresponding Speech-Language Pathology and Applied Behavior Analysis Special Interest Group. What are we talking about today?
Today, we are talking about service delivery models, especially service delivery models in schools.
So when we say service delivery models, we are basically talking about what in general?
We're talking about a few different things, right? We're thinking about frequency and duration. We're thinking about the place where the service takes place. We're thinking about indirect versus direct. So we're thinking about a lot of different variables that together make up what your service looks like.
And why did we choose this topic?
I think that sometimes we forget that there are more options than like 2 times 30 or 1 times 30.
I have something to admit.
Yeah, what is that?
I didn't know a lot of this information before we researched this episode. So I think that's absolutely true. I've been practicing, I've been a licensed speech pathologist for 13 years. And as we researched different types of service delivery models and best practices and ethics and, things that are related to this, I was a little embarrassed by how little I knew about the different kinds of service delivery out there.
Well, and I think it's interesting, and we'll talk about this throughout this podcast, but part of that, I think, connects back to the specifics of your work environment. And one of kind of the ongoing themes throughout this discussion that we're going to have today is, our place as speech pathologists in our work environments to help bring forward that information so that not only other speech pathologists are aware of these different service delivery options, but other team members and, more importantly, administrators of these different programs are aware of the range of service types that can be provided, as well as the potential benefits to those different approaches, depending upon the individual client needs.
And I don't think that you said this yet, but we did say that the majority of the information in this episode is related to schools. But there are a lot of variables that can be applied to different components of service delivery models, and those variables are very applicable to different settings. So just because we're talking about it in schools doesn't mean that you can't consider some of these variables if you're in private practice or working in an outpatient setting.
I felt the same way as I was doing the reading to prepare for this episode. I felt exactly that. I think that this thought process, while a lot of what we're talking about, the articles that we read are really geared toward a school-based speech pathologist, I think that they're important things they would have been important things for me to know and think about when I was working in outpatient or in private practice, So I think that there are important pieces to take away regardless of your current work environment.
And I think the funding source is a variable also. And that's not really something that we are going to review a lot today in terms of the literature and what's out there. But, if you're working in an outpatient setting, your funding source could dictate what kind of service delivery or what setting you are allowed to do service delivery in. So
Mhm.
their service delivery in general can be, you know, have a lot of different things, have a lot of different components depending on where you work. And we're going to talk mostly about things in schools, but keep in mind it can be applicable to a lot of different settings.
Agreed.
So we have
So what are our learning
Oh, I was
objectives?
just about to say,
Oh.
learning objectives. Okay, learning objective number 1, explain the components that are involved in service delivery within common pediatric treatment environments. Number 2, explain the difference between direct and indirect service and what factors might indicate a need for which type of service. And learning objective number 3, describe a workload approach to caseload and identify how service delivery components and variables are likely to impact workload. I'm excited for that last one. I
It's
hope
going to
other
be
people
good.
too. So in terms of the first learning objective, number 1, explain the components that are involved in service delivery within common pediatric treatment environments. Um, so ASHA has a lot of resources about service delivery. The bulk of what we're going to talk about in terms of this first learning objective comes directly from the ASHA website, a page entitled School-Based Service Delivery in Speech Language Pathology. There is a link on our site. I'm pretty sure this information is up to date. We're recording this episode in July of 2020. So if you are interested in doing some more reading or doing a deeper dive, I definitely will direct you to there and give credit to all the things that we're supporting this first learning objective are pulled directly from that page. So according to this reference, there are service delivery is a dynamic process and it involves a handful of different variables, and changing the different variables in this dynamic process will change the service delivery.
Right. And kind of to encapsulate all of that information, service delivery is where you do it. It's
Mhm.
how you do it.
Mhm.
It's how often and for how long you do it.
Mhm.
And then kind of for how long more broadly, like zooming back, like how long are you in treatment? Are you
Right. When are
right?
you
How long is
discharged?
your session? Yeah.
Right, right. So according to this reference, this resource, those components are broken down into looking at the treatment setting. So this could be the classroom, therapy room, place of employment, other naturalistic environment, the home. An example, this could be like push in or pull out in schools.
And also, when you think about your IEP, often this is delineated on your service grid. So, depending upon the state that you're in, all of our IEPs look a little bit different in the United States. But typically, you have different places where your service is documented, and one of those would be in the general education environment. Another one would be in a substantially separate environment. So that's also kind of the broader environment as to where you're providing those services.
Right. So treatment setting, and then there's format, which is individual, small group. What is the lay of the land in terms of the kind of service delivery that you are providing?
And if you look in an IEP, just thinking about school service delivery, often you'll find that information if your IEPs have a methodology section that might talk about that. It might talk about what format that looks like when you're providing that service.
Yes. So the third one is intensity, the amount of time that is spent in each treatment session. So an example of this would be thinking about frequent short sessions or longer sessions that are less frequent.
And I think that this is one place where, in schools, but also in outpatient and other places where you're, following along with a third party funding source, we're maybe not entering into the conversation thinking as flexibly about this parameter as possibly we should.
Agreed. Completely agreed. And I think that this is again where the old standard, like the way we do it this way because we've always done this way, sort of
Right.
falls into
Right.
this category. And I know depending on where you work, there could be some ethical considerations about administrators telling you, well, we give 3 times 30 for kids
Mhm.
with this diagnosis. And that is wrong. It's not the way it's supposed to be. The
Right.
the intensity and frequency of your service delivery, and we'll talk about this a little bit more, should be very specifically matched to the needs and profile of the student or client that you are serving. So,
Mhm.
to recap a little bit: treatment setting, format, intensity, frequency, and duration. And this is sort of what Amy was getting at before, like how long the length of treatment that you've received. So, I think a good comparison here would be PT. So, you were in treatment for 4 weeks for your sprained ankle, and then you're discharged. In that
Yep.
example, 4 weeks would be duration. I think for some of our more complex learners, or some of our more emergent learners, this piece of duration gets lost because in my old outpatient clinic, we referred to them as lifers. They had been in therapy with us for years and years through their entire elementary school experience. They were
Mhm.
coming every Tuesday at 2 o'clock or whatever. So sometimes in pediatrics, I think that component of duration can sort of fall through the cracks, but it is something that should be considered when you're thinking about components of service delivery. So ASHA states that choosing service delivery it should be a fluid process. On the page that I described, they cite a lot of literature describing how important it is to understand the different kinds of service delivery models, and to sort of break away from that traditional, we do it this way just because we've always done it this way, or really thinking about it critically outside of the norms of your workplace setting. Um, this site and about all of this literature really does highlight that student outcomes are improved when these different components of service delivery are used flexibly, when they're reviewed regularly, and when they're changed specifically, when they're changed because of a direct relationship with the student needs. And this component was like a surprise to me, but also not a surprise. I think as clinicians, we change our programming, we change our materials, we change our goals and objectives, we change all kinds of things related to the specific needs of the client and how they're progressing, and how, they're about how things are moving along. So on the one hand, it's not surprising, but on the other hand, I think thinking about customizing service delivery based on an ongoing basis, based on the needs of your client, is not something that we as clinicians do automatically.
Well, and I think this is such an interesting and powerful point, because I think often service delivery feels somewhat set by the institution,
Mhm.
right? Regardless of where you are. And I think back to working outpatient, outpatient, you're very bounded by the third payer party system, and how that works out, and what you're able to do and not able to do. And in schools, it's speech pathologists are, schools are critically underfunded, and the the number of speech pathologists who have more students on their caseload than they're able to actually adequately provide a flexible service delivery model for is far outweighs the reverse. Um,
The number of times I've heard colleagues and friends say, "Well, I see, these 5 kids in a group because I have a caseload of 140, and I
it,
can't
it's
physically,
it's disgusting. Yeah.
I can't physically treat each of these individual students, and so my service delivery has to be in a group setting."
And when you step back and look at that, it's a real challenge, because ethically we shouldn't be doing that. We
Right.
shouldn't be doing that. That shouldn't be a deciding factor in service delivery. So I think this is a really interesting point to kind of ponder, the idea of that being as fluid of a process as writing your goals and objectives. And I think, when we get together and thinking about school based, where you're writing all of these things as a team, as opposed to something like outpatient or private practice, where you're sort of making those with input from, some stakeholders, but not necessarily a larger group. Uh, it's interesting to think about, okay, if you come back to the table and a person hasn't met their goals and objectives, should you approach service delivery options with the same flexibility that you would in potentially rewriting that goal? So I think that that's a very interesting thought, and not necessarily how it plays out in a lot of places. And maybe we need to be more aware as clinicians that this is something we should be thinking about as
100%.
as part of the decision making process.
So the different components of service delivery, the treatment setting, format, intensity, frequency, and duration are all going to be affected by a lot of different factors. One of which is age. So if you're talking about birth to 3, IDEA Part C dictates that services need to be family centered and they need to take place in the natural environment. That shouldn't be a surprise to anyone who's spent any time in early intervention on the floor in the home.
Right.
Um, that changes though between ages 3 and 21. So Part B of IDEA dictates that preschoolers and school age students be provided with a free and appropriate education, which is the acronym for that is FAPE, in case of anyone has heard the term FAPE, free and appropriate education. It also dictates that those students be educated in the least restrictive environment. So then it becomes, in terms of thinking about service delivery, what is the least restrictive environment for service delivery? And how do you need to consider that when constructing your service delivery? You can definitely make the argument that a pull-out session where you're taking the kid out of their regular educational environment into your speech resource room or your speech room or your office or wherever it is a more restrictive environment than pushing into the classroom. So there's all of these different components to think about in terms of what is dictated by IDEA when you're choosing service delivery.
Well, and I think back to the point of it being a continuum of service delivery options, that's where, you could almost make yourself like a timeline type graphic that is the continuum of restrictiveness of environments. And perhaps when you have a student who's learning some skills for the first time, they do need that, you know, outpatient type level of restrictive environment, quiet space, no distractions. And then perhaps you move toward that continuum of less restrictive environment to sort of generalize those skills. And if we're not thinking flexibly about what our service delivery looks like, we're going to be sort of locked into something that is not necessarily ideal service delivery over the duration,
Right, exactly.
perhaps.
So Asha gives us a nice long list of different things that we need to consider when deciding on these variables of service delivery. One of them is age. Another is student progress and changing needs throughout the year. And this is throughout the school year. If you're working in an outpatient clinic throughout however long
Your
you
research.
are, you have identified as the course of treatment or the duration of treatment, your service delivery should change as your student or client changes. So as you see changing needs, it's really your response, it's really important for you to consider whether or not the service delivery needs to change along with the student. I think a great example of this is generalization of skill. That's something I think probably comes up a lot. So you've taught Johnny how to, I don't know, X, Y, and Z, whatever skill it is you're teaching in your quiet white room with no distractions down the hall in the speech office. And it's time to generalize. Please don't generalize by giving him a different game or a different set of materials. Consider changing your service delivery and do push in the classroom or go into the home or go with them to Dunkin' Donuts or go with them into a different setting. Think about changing that setting variable to help facilitate generalizing that skill in a novel environment. That's just an example. It's one way that you could change your service delivery, but I think that's a common one.
Yeah, and I think, along with that is different types of service delivery, right? You could shift from a direct service delivery where you're the person providing the service to an indirect service delivery, which we'll talk more about later. But I agree, we should constantly be assessing kind of the overarching goal of our goals outside of our restricted environment.
I just thought of another one. Format,
What
change
is
the
it?
format. So
Change the
if
format.
you're teaching social skills and you've taught Johnny how to so beautifully ask a reciprocal question or make an eye gaze shift towards a communication partner in an exchange or take turns, try switching to a group. You can't practice social skills
Hmm.
without peers. You can't practice social skills without social opportunity. That's another way to consider, that's another common theme in pediatrics, I think.
Or you're running your pediatric group and your client is doing a great job in this small, highly controlled, structured group that's, maybe 30 minutes in duration. Consider moving that group into the broader classroom. Now you're going to run your group with 30 kids
Or the
instead of
chaos of the
4.
playground. The
Hmm.
chaos of the playground. I don't know if you've ever had the experience of treating on a playground.
It's intense.
It's,
Yes.
I personally have found it a challenge. If there's any listeners out there who think it's really easy, please,
Let
please
us know.
respond
We'd
to
like to interview you.
please
Share
send
your
me an email.
tricks.
In my personal experience, and doing treatment on a playground and facilitating some of these things with the noise and the insanity of play can be, I find, a personal professional challenge.
But I think that the great point that is embedded in that challenge is the idea that we should try those challenges, particularly if we're asking other people to help
Totally.
generalize those skills. It's one thing to say this works in this one particular environment for this one particular duration in this one particular format where we're doing it with this level of intensity. Those tips and tricks that are super effective in that area of service delivery are not necessarily going to translate and be as helpful in a different type of service delivery. So by getting out of the playground, it can help just troubleshoot and make sure that either those, you might need to come up with new
Totally.
strategies for the new format and
Totally.
treatment setting.
I'm going to just run through a quick list here of some other things to consider in terms of when to change your variables of service delivery. Access to the curriculum and the different state standards, depending
Mm-hmm.
on where you live. Specific demands in the classroom might dictate different changes to service delivery, changes in the community, family dynamics, family changes, changes or requests from the stakeholders. Cultural considerations are really important. The ASHA website directs people to the bilingual service delivery and cultural competence information components on their site. Team decision making. This sort of sent me down a hole. ASHA also has an interprofessional education and interprofessional practice portal resource for
Mm-hmm.
team decision making that I found to be tremendously helpful.
Well, and in one of the more recent revisions of our code of ethics, they added a component about that.
Yes.
Like that's
Yes.
a relatively new addition to the code of ethics. So
And
it's
it's
it's a
so
big
important.
it's a big deal. Yeah.
It made me it gave me all the happy feelings. So yes, team decision making is a variable that could change the way you're thinking about your service delivery. On this page, there are a number of evidence-based practice studies that have been conducted looking at the different service delivery models. We're not going to go through all of them. There's a lot of authors cited here with a lot of really great research about the different components of service delivery. I encourage everyone listening to go through that list of research and do some nerdy reading if you are so inclined to learn more about the literature supporting different types
Mm-hmm.
of service delivery. I want to talk quickly about, I also want to talk about setting.
Yeah.
So we've talked about this a little bit, thinking about our speech room being the place where we provide direct service in our, we've got our we love speech signs on the walls and
Mm-hmm.
our like caribou game that we bought on eBay for
For so many
$700.
dollars. So many dollars.
Why did they stop
Caribou.
making
Who
that
knew?
game? It's
I
so
don't know.
annoying. But there's so much more to a setting when considering appropriate service delivery. So, and each setting has different pros and cons. So your quiet room is controlled. It's free of distraction. It might be a great place for teaching certain skills, but there are fewer opportunities for generalization. When you pull a student out of the classroom, you're reducing their instructional time and possibly reducing time with peers. Um, Another component is the integrated or in-class service delivery model. So pros for this, you're working closely with other staff. You have great opportunities for collaboration and cross-pollination of ideas and issues. The not so great things about this, though, is that could be a busy and noisy environment. You have less control over distracting stimuli. Those are things that you, depending on the profile of your student, might be really, really important variables to modify.
And even within that, when we think about some of those other factors from the beginning, like your format, there's a lot of variability even within those two, like pull out versus push in sessions, depending on if it's individual, if it's small group. I think you're also trying to weigh the balance, particularly when you're school based. All the time is coming from somewhere. So you also want to be weighing, perhaps your client could acquire the skill in both environments, but if your personal data, and their clinical history demonstrates that they're more likely to acquire that skill in, a month rather than 3 months in the quieter environment, then making that choice to provide those services in the more restrictive environment might be the right choice. And it's a conversation that people are having. They're all team decisions when you're looking at a school-based service provision, but thinking about those variables as well. Okay, well, perhaps we could acquire more skills in a shorter duration if we're working within this particular setting and with these particular types of frequency and intensity. So they're all things to be weighed in the consideration process.
Totally agree. We're entering into the portion of our research that was news to me. So I don't know if this was any of these things were news to you, but so we've just reviewed, pull out, doing your treatment session in your sterile white room or your speech resource room or your office or wherever, integrating
or your closet or your like
right.
vestibule of the women's room, or depending upon your environment. I mean, like you're kind of hoping for a sterile white office, but
the women's room.
Worked in some weird places.
Oh my God, is that true?
Not in the vestibule of women's, but yeah, I've been in a closet with a boiler and no windows at all and storage materials.
Oh my God.
Yeah.
Oh, that's wild.
Yeah.
That never happened
Yeah.
to me. Good Lord.
Yeah, well done.
No, seriously.
Yeah.
So again, just to sort of recap, pull out speech room, speech office, boiler, basement, wherever you wherever you are, told to work on your own one-on-one with your client. Integrated or in-class services, or a push-in model where you're doing it in a more naturalistic environment or in an educational setting. Then there was supportive teaching, which I had never heard of. So this website, and I'm just directly quoting the ASHA website that we've referred to, the link is on our thing, a combination of pull-out services and direct teaching within the classroom. So I had never personally been a part of a situation where the speech pathologist is given an opportunity to teach in the classroom in supporting the classroom teacher. I thought that was really interesting. Then there's complementary teaching, where the classroom teacher presents the curriculum content as the primary instructor, and the SLP assists specific students with work completion. Also a very interesting model that I was not aware of. Station teaching, never heard of this one either. Instructional material is divided into parts with the SLP and the classroom teacher, each taking a group of students. Students rotate to each station or learning center for instruction. This sort of reminded me of like the preschool stations that my kids had in their preschool environments. I'm not sure if that's accurate or not, but it's what it reminded me of. Parallel teaching, where the students are divided and the classroom teacher and the SLP each instruct a designated group of students simultaneously, with the SLP taking the group of students that needs more modification of content or slower pacing in order to master the educational content. Thought that was a really interesting model too. Team teaching, the SLP and the classroom teacher teach the academic content together, allowing each professional to provide his or her expertise. I had never heard of that. Have you heard of any of these? I'm just listing a bunch of
I've done a number of these. I think part of this being novel is because of your work environments, because have you been
I have
never been like a public school staff or a charter school?
To public schools like way back in the day, but I have never been an employee. I have never been an employee of a public school. So this is probably my own limitation, but this is why this is so great, because I'm learning new things.
Right. And it's good to learn new things.
So let me finish reading this list, and then maybe with your experience, you can tell us what you think about some of these things. There was team teaching. I think I went over that already. Supplemental teaching. One person, usually the teacher, presents the lesson in a standard format, while the other person, usually the SLP, adapts the lesson for different students. This is all, again, just to cite the reference, this is all coming from the ASHA website with the article called "School-Based Service Delivery in Speech Language Pathology." The link will be up there. All of those definitions were a direct quote, just for the sake of saying it. What do you think about those different teaching models in your experience, service delivery models?
So I think all of those models have a lot of merit and a lot of challenges in the school system. So having worked in a number of public schools and like sort of in different geographic areas in the country, and also charter schools, doing a lot of those well is really dependent on funding and time.
Mm-hmm.
When you look at the more involved teaching methods like co-teaching, I think they called it team teaching, but co-teaching, where you have two teachers, and one of the teachers is a speech language pathologist, and one of the teachers is an educator, a grade level educator. There's a lot of planning that needs to go into that in order to have that be an effective modality. It can certainly be an effective modality, but it's essentially what the school is doing is essentially hiring two teachers to teach one classroom. When you're looking at sort of stations or something like that, or having the SLP come in and sort of be a guest lecturer, essentially. So maybe the
Right.
SLP comes in and takes lead on a lesson about pragmatics or social skills. That's something that you'll see a lot. When you're doing something like that, you still need time to do that connected indirect service so that the speech language pathologist has time to connect with the teacher and provide the consultation, because ultimately why you would use an approach like that is so that then the teacher can carry over the primary content from that lesson across all of the students' school day. So if you're, using some type of pro-social curriculum and the speech pathologist perhaps leading that lesson in your classroom, you need to have the educator, first of all, there for the lesson, but also there for the planning of the lesson,
Mm-hmm.
and really taking an active role in carrying over the key points throughout the school day or the school week.
Such
Station
good
teaching
points.
is, that's a little bit more straightforward. You could just kind of come in and do a standalone activity. I agree with you. I think often that lends itself better to kind of the lower, earlier grades, but you could also make a point for that perhaps in an upper level English language arts type class.
Mm.
But these are all important service delivery approaches to be aware of and to know that they are an option. I think it's also really important to understand when you're exploring these ideas that you certainly need administrative buy-in, and you need buy-in from your co-teacher. So you both really need to be
Mm-hmm.
open to being flexible, working with
Have a
one
good
another.
collaborative relationship, all of that kind of
For
stuff.
sure. For sure.
The last setting that they review in this article is telepractice, which we have all had a hot minute to adjust to in the last
Oh
couple
my
of months,
goodness.
but that is, a different setting to consider. And I think it will be interesting moving forward how this, embracing telepractice through this pandemic, because we're recording this in July of 2020,
Right.
is
Right.
is going to change how people culturally embrace the use of telepractice and using telepractice as a service delivery model.
Well, and I think as somebody who's jumped in with the rest of the speech pathologists in the world to learning a lot more about telepractice than you ever thought that you would, one thing that has come up for me is the idea that in some areas of the country, in some geographic locations, they're actually accessing telepractice perhaps as the primary modality for speech
Mhm.
language pathology services for students. So it's going to depend on where you are. If you're in a rural location, you may already be using telepractice with a telepractice facilitator. And then telepractice itself, to me, kind of bumps up as an additional layer to those considerations that we were thinking about at the beginning. You're thinking about your treatment setting, but where are you receiving that telepractice and in what format, and
Mhm.
with what intensity, frequency, and duration? So,
Telepractice is going to be interesting, I think,
mm-hmm.
no question. So moving on, one of the last components to consider, one of the last variables to consider in service delivery is scheduling. So loosely referred to how often you are like scheduling your not to use the term in the definition of the term, but how often you are scheduling your therapy sessions.
That's right.
For our frequent listeners, I have been teased once before about having a third grade ability to define terms because I use the
Using the
definition.
word in the definition.
I think everybody understands what I mean when I say scheduling is scheduling.
Scheduling,
Scheduling is scheduling your clients.
selecting the
So there's
time, and
right, right. So there's the traditional weekly schedule. There's a receding schedule, where direct service is more frequent and then reduces over time. There's a cyclical schedule where the SLP provides service for an amount of time and then follows up with no service. This is something that comes up a lot. At least I've been reading a lot recently that I think is a very, it's becoming more common, is something called the 3-to-1 model. The 3-to-1 model is an example of a cyclical schedule. For those of you who don't know, the 3-to-1 model is the where there is direct services provided for 3 weeks in a row, and then the fourth is the fourth or the one is indirect service on the fourth week of the month. So this is very casually referred to as the 3-to-1 model. That is an example of a cyclical schedule. There are collaborative schedules where the schedule is based around observations, meetings, sharing information, collective and collaborative discussions around the student. There's a block schedule, which I haven't worked in middle schools or high schools very often, but these kinds of schedules follow a middle school or high school's master block schedule, where the sessions might be longer than you would typically see in a pediatric IEP, but they're less frequent. So it sort of jives with the way that the middle school or high school is operating in general. Blast or burst schedules, where the SLP provides short and intense services. And this allows the SLP to provide individual direct service with less time to travel around the therapy room. To travel from the therapy room and to the different locations. And then finally, group size. So if you're using group scheduling, then it's going to be affected by a lot of different variables like the grade level, similar IEP goals and objectives, different, varying levels of need, et cetera, et cetera. So just to sort of recap the first learning objectives, there are a lot of variables that go into service delivery, which means that you have a lot of flexibility in tweaking each of these individual variables. And we are going to talk more about scheduling as it relates to workload or workflow.
Workload.
Ta-da.
Ta-da.
Moving on. Objective number 2. What is objective number 2?
Direct and indirect services.
Yes, direct and indirect services.
So that's another important consideration, right? Should you be providing direct service? Should you be providing indirect service? Is a combination of both really what's best? So when we think about direct service, I think that that's what most people picture when they picture a speech and language session, right? It's the SLP providing services to a client face-to-face, synchronous, it's happening in real time. Now that could be, as I've learned through all of my telepractice education recently, that could include virtual face-to-face synchronous service is direct service. So the speech pathologist could be providing service to the client through a virtual platform. This is what you think about when you think about traditional treatment, when you think about evaluations, the conducting of the evaluation, not the writing. And it's not the only kind of service delivery. Often it really should be supported by some indirect service or at least indirect activities. And this can be confusing for administrators to understand. We have productivity requirements in healthcare or outpatient. We're working toward a rationale for a workload model instead of a caseload model in school environments. But sometimes what I've found, just having worked in a number of different environments, is there really is sort of this misplaced emphasis on direct service as sort of the only service that matters. And so that brings us to indirect service.
Indirect service. What is indirect service?
It's consult, right? That's what we think of with consult.
That's what I think of, yeah.
Right. That's what I think of also. So it's service delivery. It's clinical in nature. So indirect service is different from indirect activities. And I think that that's something for us to kind of wrap our heads around. So when we're having these conversations with administrators or other people, you have indirect clinical service, which is really ongoing support, communication, consultation with specific team members, staff training, those types of things that are very client specific and face-to-face with somebody else. And indirect service can be really, really relevant. It can be relevant for clients who are working on pragmatics, expressive receptive language, complex communicators, really anybody who's getting support from other communication partners in order to be successful in generalizing their target skills outside of that kind of sterile therapy room or, therapy room full of boilers and mice and dust, but like wherever your
Oh,
therapy room is.
horrible.
Yeah, it was not great.
If anyone out there is listening to this and has a story about the weirdest place that you've conducted
Yes.
therapy, I would
Yes.
love to
That would be a
compile.
fun list.
That might have to be, for those
Get
of
a
you who
tragic list.
have been following us, I learned how to use Instagram. We learned how to use Instagram. That might
Mhm.
have to be like an Instagram poll. Where is
Yeah.
the weird? Okay, sorry, I've just hijacked
Yeah.
this whole thing because I think that's
No,
really
it's
interesting. But
yeah.
anyway, as you were saying,
Yeah. So when we're thinking about that direct service that takes place either in that room or in a broader, less restrictive environment, the piece that goes along with that would be the indirect service. And when you were talking earlier, Kate, about the different types of collaboration and co-teaching sort of that can happen, this indirect service is a required component of that. So
mhm,
the direct service piece is the SLP perhaps teaching the lesson or co-teaching the lesson or running a center. That's the direct, that's the face-to-face. The indirect is all the components that happen between the SLP and the teacher or the other educators or the paraprofessionals before that happens and after that happens on an ongoing basis to make sure that that one brief direct moment is carried through into all of these different tasks and is actually effective. I think a huge challenge for indirect service is that it's not a billable service.
mhm.
A lot of the time, it's not a billable service, and I mean, I can't think of any environment where I've been in a billable situation and that's been billable.
I think it depends on your funding source. So this is a
Yeah,
billable service if you have private pay.
right. I guess that's true.
I
Yeah.
think, if it's possible, but it's not considered a billable service through Medicaid or through insurance, which is, I think, what
Hmm.
sets the standard. And we had said this in our collaborating with BCBA's episode. If anybody is interested in
I
organizing
know.
boots on the ground for advocacy around getting billable codes for indirect service, that would be a tremendous, tremendous addition to our practice.
Well, because, I think that the lack of ability to pursue reimbursement for these services can lead to a misperception that indirect services aren't necessary or as important as direct service. And
Oh my God,
I
yes.
disagree very much.
Yes.
I
Oh,
disagree.
I have very, very big feelings about that. I think some of the best cross pollination and best components of what we do as a field happen through indirect service in terms of collaboration, interdisciplinary structures, team approach to treatment, all those kinds of things.
And I think as somebody who has worked in a lot of different environments, the understanding of the importance of indirect service is very it's very varied depending upon where you work. But like if you step back and think about your work environment, are you somebody who has time in your schedule to connect with other team members or outside providers to provide training or other types of consultation, or are you expected to do that during your lunch or after work?
Right.
If you're in a school, do you write those services into your IEPs? Is consultative service considered when you're building your schedule? Or do they
Right.
say, oh, just book all of your direct service and like do the consult in passing when you have a minute?
Right.
Uh, if you're in outpatient or you're in private practice, does your productivity model account for indirect service in your building of your schedule? Are you expected to make that phone call? You're a pediatric outpatient clinician. Are you expected to call all of the speech therapists for all of the students in your entire caseload during all of your lunch breaks, or are you going
I
to do
would be
that at
willing to
night?
put money on the fact that that's not
Right.
built into the schedules of people. Having worked in a couple of different outpatient and looked at the budgets of those the
Hmm.
kinds of models, I mean, it's not a billable service, which is just a crime.
Because it's related to clinician excuse me, it's related to client outcomes. So I think that that's the important piece there, and why I personally feel like it should be a billable service. It should be a service that we look at as just as important as direct service, which takes us next to the kind of indirect activities that aren't necessarily directly connected to your client. It's not a consultation, but they're also things that you need to do as a speech language pathologist, right? So wherever you work, there's some kind of paperwork. Perhaps there's a mountain of paperwork that's like burying you over time, right? Just like so much paperwork. You may have billing, staff meetings, all of those other things. Those wouldn't be considered indirect clinical services, but we'll talk more about those when we get into kind of the last learning objective about workload. But just so you have in your mind a separation, a clear separation between, there's a lot of indirect things we do, only some of those are indirect
Mhm.
clinical services. So, okay, we've got all of these different things that we're thinking about when we're thinking about service delivery. How on earth do you figure out what is best for your client?
I don't know. I'm just a speech pathologist. What do you mean?
Well, I don't know the answer for everybody's client, but I
I know.
know
I don't know. I have no idea. It's a complex, dynamic process.
it is. It's a complex dynamic process. And if you know us, you know we love Joy Zaballa's set framework.
If you
And the
haven't listened to
set
that episode, it's the best episode
Oh,
ever.
you should. It's so good. She's so good. So the set framework is a framework for considering assistive technology. But I agree with her, and I feel like it's also a framework for life. And so I kind of use that framework to approach any sort of big complex problem with lots of different pieces. And I think this is one of those, right? So
Mhm.
there's a lot of different variables that you need to kind of examine to make an informed decision about what you're doing moving forward with a particular client, or to revise your initial thoughts about what made the most sense because they've changed or some variable has changed. So if you're not familiar with it, listen to the podcast. She's the best. But it stands for Student Environment, Task, and Tools. So here, if we take the first step of that acronym and we think about the student or the client, we're thinking about what are their individual needs, right? So we're using an evidence-based approach. We're integrating the existing literature. If you're not familiar with ASH's evidence maps, they can be really helpful. So if you're looking up, particular areas that you're targeting in therapy, you can get sort of a synopsis of the key research out there. So maybe you find some literature, maybe you don't. Either way, you're integrating that with your particular clinical knowledge, your experience as a clinician, and also your experience with your unique individual client. So what has worked well for them in the past, and think about service delivery models there, right? Think about those same variables. Like, does it matter where what the environment is? How does this person, once they've acquired a skill, is it really easy for them to sort of just start using it in different environments and with different people? Is that something that needs to be scaffolded? If it does, are there supports that need to be in place that the communication partners need to be made aware of? And if so, think about indirect service there. That's kind
Right.
of an indicator that you should be considering some degree of indirect service. Think about the environment. So that second letter in her framework, the environment, and not just your work environment. So I think this is a piece that's relevant no matter where you're working. So if you're an outpatient, and particularly if you're in pediatrics, think about all the different places you want your person, your client, to be successful, right?
Right.
It doesn't really matter if they're just successful with you. I mean, that's
No,
lovely.
no, that's not the point of our jobs. If they're just
Right.
successful with you, then you have not done your job.
Correct.
That is not rehabilitation. It's not.
And I think it's a bigger challenge. And I always felt that this was a bigger challenge when I was working in those environments, because you're not as ingrained in your clients' other environments in their life. Like, you may have a nice amount of contact with the parent or the caregiver, but you don't know what their classroom looks like, and you don't know what different groups they're in. You don't even know what their playground looks like, or what are the cool games that kids are playing these days, right? Like, you don't know any of those pieces, so you're at a disadvantage for in a lot of ways. But as much as you can, inform yourself about those different environments. Think about the important pieces to enhance their functional outcomes across those different environments. Then you're thinking about those tasks, like what exactly is it that you want them to do? And again, being aware of the environment, you might be working on, maybe you've been using some social thinking strategies. You run an outpatient small group, right? You have an outpatient small group, and you're working on whole body listening. It's awesome. It's going super well. You have certain cues that you're using. You have explicit instruction that you're using that's making this group environment successful for your client. And you're like, oh, this is great. I would like them to do it all the time, all the places with all the people, because we want our clients to be successful, and help them have positive, meaningful change in their
Right.
lives.
Go
So when
figure.
you think, right, right. So when you think about the environment, you want this success all the time. If you don't have some level of indirect service there, how are you going to communicate
I
this?
know. It boggles my mind that indirect service is not a larger. And I think I have a twisted view because I'm also a BCBA, and an indirect service for BCBAs is a massive piece of their jobs. And
It's
it's
such an
billable.
interesting perspective.
And
Right.
it's billable. And so as a speech pathologist also, it's like, guys, there's so much value in indirect service. Why aren't we doing this more? Why aren't we embracing this as as a major fundamental component of what we have to offer teams, what we have to offer families, what we have to offer our clients? I think we definitely need more advocacy in this area.
Well, I agree. I mean, I think as a whole, when we advocate as a group, speech language pathologists, for the services that our clients really need, we're helping to further the field. So, perhaps your administrators, maybe you're in a productivity driven model and they don't understand, or they don't really care about the importance of indirect services. I think that we really need to keep having the conversation again and again to just help shift the culture more broadly toward an understanding that both direct and indirect service delivery approaches are meaningful and important. And that is also a continuum depending on an individual client's needs. So, some ways that you can just think about are, can you collect some data? Are there data points that you can collect on an individual client basis that maybe connects with different types of service delivery?
Mhm.
Maybe you just start having the conversation that there are these different types of service delivery and it exists on a continuum, and that your ultimate goal is positive outcomes for your clients across environments. But I think as a whole, the more often we bring it up, and it might not be in the conversation that I have with my administrator, or the conversation the SLP after me has, but perhaps, the next SLP who has that same conversation again is going to break through. And I think also we as the group should think about building our skills and perhaps, becoming part of administrative teams in different environments too, and help shift the movement that way. But
It's a
I think we're
movement,
on to
people.
workload, the
Indirect
service movement.
The indirect service movement. Okay, learning objective number 3, workload. Specifically, I'm looking for my notes here to read the actual learning objective. Describe a workload approach to caseload and identify how service delivery components and variables are likely to impact workload.
Mm-hmm. ASHA has some great resources on workload. Their workload content is very focused on school-based settings. Again, I think there are unique variables that are certainly specific to being in a school setting, but some of that information might be helpful in facilitating a conversation regardless of your work environment.
Mhm.
They've got some really nice documentation. They've got some good tools up there. So now I'm gonna be Kate. What is a workload? It's the work. It's the work that you do.
Wait a minute. You can't say a bad definition and then say that it's me. I got street cred, man.
Just using the word in the definition.
Right, I know. I got it.
I know.
Workload is work.
It's the work that you do.
It's the load.
It's all the
that
load
you carry with your work.
If you put all of your work into a wheelbarrow, that would be
the load.
your workload.
Let's keep saying the word load. Oh, maturity.
Yeah.
Workload is important.
It's super important. And when we think about how it relates to service delivery, right, we have, ASHA has a really nice visual depiction of this, but essentially, you have direct service, you have indirect service, but then there's all of these other things, right? And all of these other things vary depending on your work environment. But, direct service, yeah, that's workload. Indirect service, workload.
Yep.
Writing up assessments and insurance reauthorizations,
Bet you couldn't guess. Workload.
Submitting billing, workload. Attending staff meetings,
workload.
You modify and make some materials, workload.
It's so much.
It's so much things.
There's so much.
So much things. So many things. So many things. Oh boy, we're falling apart at the end here. There's a lot of stuff. Anything from bus duty to cleaning up after your session. These are all tasks that you need to do during your day of work, which is a load. So why did ASHA come out with a workload approach to caseload?
I mean, it makes perfect sense. That's the way it should be. That is the way it should be.
And that is the way it is for so many other jobs also.
Yes. Well, and I feel like I'm not going to articulate this well, but I feel like our job isn't we're not being paid by, like, some people, like, let's say you're a contractor and you're paid by the number of items that you produce, right? Our productivity shouldn't be on the number of people that we treat. It should be on the amount of, not all student is created equal. Not all client is created equal. There are so many different components. It's not like we're in an assembly line and we get paid for every button that we attach to a pair of pants. I can't
Correct.
think of a better analogy, but this is not a field where our output is driven by production of
Right.
items. So
Right.
why is it by caseload instead of not by workload? It makes perfect sense to me. I don't think I articulated that well, but I'm passionately waving my hands because I feel
I
strongly.
can see that, and I feel the
strongly about it.
passion. I am there with you. I agree. I mean, caseload doesn't even begin to describe it. It really
True.
doesn't.
Right.
And I feel like part of it is because we place an overemphasis on direct service, right? So when all
Agreed.
you're thinking about is direct service, then maybe that's the only thing that employers are considering is the direct service portion of the job. Or maybe you're somewhere that does understand and acknowledge the importance of indirect service, which is fantastic. And definitely there are many places that do.
I think if you're in a place that doesn't, you can take these resources, the actual workload resources, to your administration or to the rest of your department and try and advocate for change.
Right. And there are some other helpful documents just to draw your attention. In 2014, the American Occupational Therapy Association, American Physical Therapy Association, and ASHA came out with a joint statement about workload. And basically they're making the point that caseload doesn't adequately capture all the services. Like, anybody who's worked as a therapist is aware it doesn't. And so when you're thinking about services you're providing, particularly in a school environment, we really need to be advocating as a group for a shift toward workload. And here we are. They wrote that statement in 2014, and here we are, and it's 2020. And I don't think that the workload approach is nearly as widely adopted as it should be.
Right.
And this statement, the resources from ASHA, they're all geared towards schools, but having worked in a lot of different outpatient pediatric settings, my personal bias is that this thinking should be applied to some degree in those environments as well. And I recognize you're striking a balance between revenue and you need to have enough money coming in to sustain your business. But the current medical model really does lend itself to like fragmented and poorly coordinated services for clients who are receiving services across multiple environments. And that's unfortunate.
Which is another reason to advocate for billing, for being able to bill for all of these other things we do that are not direct service. It's all tied together. It's all one big messy pile.
Yeah. Because think about, I've been on both sides of that dynamic. I've been the outpatient therapist and I've been the school-based provider, and everybody wants to be able to connect. You want to be able to connect. You want to be able to work collaboratively as a team. You want to be able to be using the same cues, or at least know that somebody is using certain cues in a certain environment. And that's really a place for indirect service. So we direct you back to ASHA's practice portal on caseload and workload for nitty-gritty details, and again, like helpful links to other resources. But key takeaways that feel quite common sense to me would be that students who are seen by SLPs with smaller caseloads tend to make more progress. So
I believe that.
And why do you believe that, Kate?
I don't know. Because it's common sense.
It is common sense, right? So time, it comes back to time.
Because the example that I gave before of a colleague of mine who had a caseload of 140, and she had to see them in groups because she had no other choice. She's only one person. She can't physically be in a million different places at the same time. Those students didn't get in the customization of service delivery that specifically matched their needs. So, if you have a workload that is totally unreasonable, then you're not going to be putting your own clinical resources to match the needs of a client. I said that very articulately, but the short answer is that it makes sense. It's just common sense.
Well, it is common sense. And all of these, the reason that we've connected all of these topics together in this talk is because they're interconnected, right? If your workload is out of control, you're not able to apply the critical thinking skills that you should be applying to your service delivery consideration and decision making. That should be a variable that you're allowed to consider and
Right.
modify as needed on an individualized basis. But if your workload's out of control, all of your ability to make active decisions in that entire parameter of therapy are gone out the window.
Right.
Okay, so that one makes sense. The students who have SLPs with smaller caseloads tend to be making more progress, probably because they're receiving more individualized service. But SLPs with higher caseloads have a harder time keeping their staff.
I
Also, not a
mean,
shocker.
do I need to break that down? I don't think so. I
I
think
mean,
that's
I think,
pretty reasonable.
again, makes sense. Also, if you're listening and you're a speech pathologist, we went into the field because we want to help people. And so if your workload is keeping you from applying clinical decision making to the full continuum of service delivery options available,
Which
keeping
prevents you from reaching your professional goals and is
and
not aligned with your professional values.
and you have your clients who should be making progress, but they aren't, how does that make you feel?
Icky. No
Yeah,
thanks.
bad.
Bye.
It
Peace.
yeah, gonna find another job because
Yep.
this job just like hurts my heart.
Oh, that was
Or
so sad. Hurts my
I
heart.
oh, it's yeah. I
It just makes
the
me
the
angry.
the flip side of that is like, or you're struggling, you're bringing home hours and hours of work every night. You're working every weekend. How
Mhm.
does that make you feel? Burnt out. Like maybe you don't
Right.
even maybe you don't stay in that job. Maybe you don't even stay in our field. So
And
I
I
think
mean, it's no newsflash that burnout and turnover is an issue in general in our
mhm,
field at large.
yep.
And I think that these are all interrelated variables.
Yeah.
It's not, isolated. It's not an isolated issue.
So if you're not using a workload approach, start with a practice portal, get more information about why you should be, and then think about the specifics of your work environment and how you might go about shifting your policies a bit. So you might speak with or even join an administrative team of your district's union if you're in a school.
Oh, good one.
Most school-based SLPs are part of a union, but aren't part of the in charge part of the union. And the people who are educators and don't understand how our licensure requirements or intervention approaches are different from teachers. So that's one thing to think about. You can also think about like what I think of as like sort of bridge options. So these are the scheduling pieces that Kate mentioned earlier. If you're locked into a super rigid 2x30 direct service type of model, think about just moving toward other things like a fated schedule. So maybe more intense services initially, planned reduction of service. Maybe you start with a larger proportion of direct service, you reduce that, you increase indirect service, playing with your duration of your session or your what is the word they use? They use a different word for that, but how long or short your sessions are and how frequent your sessions are. So something like, 10-minute RTIC drills or doing things like that, which may even be part of RTI in your school.
Intensity is the word that they use.
Intensity, that's the
Yeah.
one. Thank you.
The amount of time spent in each treatment session, intensity.
And then another option would be a defined indirect week option. So like the 3-1 model that Kate talked about, where you've got direct services happening every 3 weeks and then a fourth week is indirect. When you're having your discussions with your stakeholders like administrators, but that also includes parents and guardians. If we're
Mhm.
thinking about school-based providers, you want to be informed. You want to be prepared to discuss why it makes sense for the client. And so that's your student and why this flexibility is important and connect it back to specific student outcomes. So we're not doing this because we are whiners and we have too much work to do at home, or we're doing it because a combination of direct and indirect service delivery options and the ability to tackle all of the components of your workload in your workday actually are connected with increased student outcomes, right? So, but change is hard, especially institutional change. So when you're talking about a big shift in the way people think about services, that might be hard and that might be scary for people. That
Mhm.
might be hard and scary for other SLPs. That
Mhm.
might not be something that everybody just jumps on board with. So share the information you have, you know, in like the classics, like keep it as jargon free as you can, be organized, and make it clear that the reason you're doing it is to help use this whole continuum of service delivery options to make sure that you're providing the most effective and efficient service for the client and the other professionals on the team. So I think taking a bit of perspective for the stakeholders and the other people and making sure that you're making it clear about this continuum of service delivery and all of these different things that perhaps people aren't actively thinking about as much as they should and helping bring people on board with the idea that these are things we should all be thinking about and having conversations about, at the very least, if you're in a school annually when you're doing an IEP. But really, it should be sort of an ongoing consideration.
I think that was very eloquently said.
Oh, thanks, Betty.
You're welcome. Well done. I think that pretty much wraps us up. I think I say that at the end of every single episode also.
I think you might. But
I think it's just a script. Honestly, people, there's no magic happening here. Well, thank you for joining us. If you have any questions about this episode, please reach out to us anytime, info@slpnerdcast.com. You can send us a message on any of our social media platforms. We love hearing from you. If you feel so inclined, leave us a review, leave us a comment. Be our nerdy friends.
Yeah,
reach out when you want.
Tell us the weird places where you've worked, and help me feel better about my boiler room experience, which really Kate did not have.
No, I never did. So that's that.
All right. Bye, guys.
Bye, everyone.